he was in a pool of melena. I would estimate like 500 to 750 cc's was just pooling in his sheets. He was still awake and alert, but did not look good. He was both jaundiced and pale, with tachycardia and hypotension. The nurse said to me, "I know his vitals aren't that bad, but I've never seen this much blood at once, and I just felt like someone should know about it emergently." And I agreed with him. If this much is coming out, how much is still left in there, and how much more blood loss is coming? Then the patient started vomiting. First, coffee ground emesis, which soon turned into bright red blood, like a ton of it.
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life.
This is part 2 of a 4-part series on liver emergencies. Liver failure affects every body system and can cause so many life-threatening complications. So last week we talked about cirrhosis and how this can lead to spontaneous bacterial peritonitis. And this week we're talking about esophageal varices. So let me tell you about a rapid response that I was called to. As I was coming down the hallway, I just knew that the patient I was about to be caring for was having a GI bleed because I could smell it as soon as I got on the unit. Sure enough, I arrived to find a 6-ish-year-old male lying in a pool of melena. Now, if you've never seen or smelled melena, let me do my best to describe it to you because once you see or smell it once, you likely will not forget it. So it looks like tar mixed with blood. It's like a dark maroon, almost black color, sticky and very pungent smelling. The smell is reminiscent of like rotting meat or decaying organic material mixed with like a weird metallic tang in the air. It is, to me, one of the most malodorous bodily smells that we get to encounter as nurses, second only to gangrene. But every time I smell it, I think to myself, what must it be like to be pooping blood? I mean, I can suck it up and smell the stuff if they have to face the discomfort of it coming out of them. So back to the patient. Like I said, he was in a pool of melena. I would estimate like 500 to 750 cc's was just pooling in his sheets. He was still awake and alert, but did not look good. He was both jaundiced and pale, with tachycardia and hypotension. I mean, his vitals were concerning, but not the worst I had seen. Heart rate 115, blood pressure 92/50, and his oxygen saturation was maintaining at 98%. The nurse said to me, "I know his vitals aren't that bad, but I've never seen this much blood at once, and I just felt like someone should know about it emergently." And I agreed with him. If this much is coming out, how much is still left in there, and how much more blood loss is coming? So I checked to make sure we had large bore IVs in place. He had one 20 gauge, so I started an additional IV and 18 gauge in his forearm, while the nurse was giving me the rest of the story. So the patient had cirrhosis and was admitted for a GI bleed and weakness. His initial hemoglobin was 6.9, so the ER had given him 1 unit of packed red blood cells and sent him out to the progressive care unit. This happened to be a night shift that I was working, and so the plan was for this patient to go for a diagnostic EGD with possible banding the next morning. They had not drawn his repeat CBC, but he had had several small melena BM since arriving to the progressive care unit, and the most recent massive one is what prompted the rapid response activation. Then the patient started vomiting. First, coffee ground emesis, which soon turned into bright red blood, like a ton of it. We gave antiemetics, which did nothing. He just kept puking, and it felt like more and more each time. At this point, his heart rate was in the 140s, and he was becoming less and less aware of the situation. When he first started puking, he was able to tell us he was about to throw up, but as his blood loss increased, he eventually just was puking, but not completely aware of his surroundings, not really protecting his airway. I could just see the shock state that he was shifting into, going from compensated to uncompensated. I no longer felt like he could protect his airway. It was time to intubate and initiate massive transfusion protocol, or MTP. So we wanted to make sure that we had a good blood pressure before we intubated. So we tanked the blood pressure with some IV fluids and another unit of packed red blood cells that were already on standby for him. I got the blood pressure to 110 systolic, and I had a norepinephrine drip ready to go. The provider and the respiratory therapist pre-oxygenated for just a couple minutes and got the airway with the first pass. The first cooler of blood products arrived, and with the help of my favorite rapid transfuser, we were able to get the first whole cooler in, my trusty 18-gauge IV, in about 15 minutes. Then we packed up and headed to the ICU to wait for the endo team to come in since it was the middle of the night. I think the patient ended up receiving a total of 3 coolers of MTP and a generous dose of calcium and some vasopressors before they were able to finally band his varices and get the bleeding under control. He crashed fast, but we were ready. I'm so glad that nurse went with his gut to activate the rapid response team and not wait for the patient to go into full hypovolemic shock before he got more hands on deck. That was a lot, but I have seen the same case over and over again. This is, unfortunately, one of the classic presentations of uncompensated liver cirrhosis. What I would like to talk about now is the pathophysiology of why liver failure can lead to a bleeding esophagus, some of the evidence-based approaches to treating esophageal varices, and what's the nurse's role in caring for patients with esophageal varices. So, as we discussed last week, cirrhosis is a chronic condition with no cure. The only treatments we have, they can slow the progression of the disease and reduce the symptoms, but we cannot reverse or cure cirrhosis without a liver transplant. Cirrhosis can develop from years of alcohol abuse, hepatitis, fatty liver disease. It's basically like the scarring of the liver that impedes its function. The liver is responsible for a lot, let me tell you. And when the liver can't do its thing, the whole body is affected. The liver thrives on a rich supply of blood from 2 main sources, the hepatic artery, which delivers oxygenated blood, and the portal vein, which delivers nutrient-rich blood from the gastrointestinal tract. However, the scarred or cirrhotic state of the liver creates significant resistance to the normal flow of blood through the liver, to and through the liver. This causes a rise in the pressure within the portal vein, which you might have heard called portal hypertension. As the pressure mounts, the body's trying to survive, and so it finds alternative routes for blood to circumvent the liver's blockade. So these alternative routes, known as collateral pathways, start to form. Among the most significant of these are the collateral vessels in the lower esophagus. So here, veins from portal circulation, specifically the gastric vein, the left gastric vein, they connect with those from systemic circulation. So these collateral veins, under a bunch of pressure, that portal hypertension, they start to swell and dilate, transforming into what are known as esophageal varices. And these varices aren't just ordinary veins. Their walls are stretched out, thin, and fragile, and at high risk of rupture. Then, when they do rupture, the result is like a torrent of blood into the esophagus, leading to severe and often life-threatening bleeding. And depending on the amount and severity of bleeding, sometimes that blood makes its way into the stomach, where it's digested and comes out the other end looking dark and tarry. But other times that blood in the stomach is so irritating that it causes nausea and vomiting, and you see the bleeding coming up and out of the patient's mouth in the form of coffee ground-looking emesis, or if the blood's not been digested in the stomach, it just looks like bright red, fresh blood and clots. Either way, coming from the north or the south, the mouth or the anus, GI bleeding is bad news bears, especially in this patient population. You see, when the liver's failing, it cannot produce essential proteins like those that make up the clotting cascade. So not only are these varicose veins in the esophagus prone to rupture, while the liver failure patient is also prone to bleeding and they cannot clot effectively. So getting bleeding under control can be a challenge. In addition to that, replacing lost blood, like with donated blood products, that also poses a few challenges. I mean, we have ways of mitigating those challenges, but you have to stay very cognizant of them so that you don't forget to address the issue. So here's the thing. Donated blood products are kept from clotting by adding citrate to them. Citrate binds to calcium in the bloodstream and hence lowers the serum calcium level. So, the more citrate-containing blood products that you give your patient, the lower their calcium goes. And the lower the calcium goes, this can have life-threatening effects on your patient's hemodynamics and even potentiate more bleeding. So I actually did an entire podcast episode about this with my friend Sarah Vance. It's episode 77. It's called The Trauma Diamond of Death, if you wanted to learn more about it. But guys, it's not just trauma patients that bleed. Any bleeding patient can face this diamond of death. With liver failure patients, especially, we have to be on top of it. So here's why. Can you guess which organ breaks down that citrate? Well, if you guess the liver, you are correct. So we have this terrible spiral of badness. Lost blood equals lost calcium. Okay. But we need to replace lost blood with donated blood products, which have citrate. But the citrate lowers the calcium. And what gets rid of the citrate? The liver. But the cirrhotic liver can't process the citrate, so the calcium continues to drop as we give more and more blood products. But calcium is an essential component in platelet adhesion and clotting ability, so low calcium leads to more bleeding. And low calcium can potentiate vasoplegia, leading to more hypotension. And vasoplegia plus hypovolemia is a very deadly combo. So the takeaway is, give calcium as you're replacing blood products so you don't contribute to this whole diamond of death. Speaking of blood products, I'm just throwing one little caveat that I learned as I was researching for this episode. So you can actually overdo it with blood products in this patient population.
Hey guys, I'll get back to the episode in just a second, but I wanted to pause to let you know that if you love my podcast but wish there were more of these awesome episodes, well, I have great news for you. There is more. My Rapid Response Academy is basically podcast 2.0, plus the huge added bonus of community. I love hosting this podcast, but it's just me, recording into a microphone often by myself. And this extroverted gal who loves to both teach and mentor nurses just wanted more. So in the community I created, I get to teach live every Friday and break down topics that I think every nurse needs to know. From deep dives into the pathophys of every emergency you can think of, to some of the heart of nursing topics as well, like how to advocate with confidence for your patient, how to de-escalate situations, how to deal with bullies on the unit, how to be an amazing preceptor and charge nurse, and some of the mindsets and boundaries that have helped me stay in nursing for the last 20 years, not burn out, and thrive at the bedside. I love the opportunity to answer your questions live, and it's such a joy to see nurses supporting each other in this community. So, if you're an acute care nurse that wants to expedite your growth as a nurse and invest in yourself so that you can provide the best care to your patients, you would love my Rapid Response Academy. So to learn more, I put a link in the show notes for you. Hope to see you there.
Now, obviously, if they are crashing and losing massive amounts of blood, then initiate massive transfusion protocol and save their life, right? Duh. But when they're not actively crashing, the literature actually supports not giving blood products for hemoglobins greater than 7. So we're only shooting for a hemoglobin of like 7 to 9 because giving more blood than is needed is actually associated with worsened bleeding, as the excessive blood volume can actually worsen that portal hypertension and exacerbate the varices. So we talked about blood products and being cognizant of the calcium when administering blood and not overdoing it with the blood products. there's a few other pharmacological interventions I wanted to review. So octreotide helps esophageal varices by causing vasoconstriction in the splanchnic circulation. This reduces portal pressure and inhibits vasodilatory hormones. So the goal here is to decrease the pressure within the varices and making them less bleedy. So next, we also give prophylactic antibiotics. Last week, we talked about how increased portal hypertension and all the pressure inside the GI system can lead to translocation of bacteria from the gut into the peritoneal space, causing spontaneous bacterial peritonitis. Well, if the patient has enough portal hypertension to cause bleeding esophageal varices, then obviously they're going to be at high risk also for SBP and other infections, which can lead to further rebleeding. So, administration of prophylactic antibiotics has been shown to improve overall outcomes for esophageal varices patients. And the last pharmacological intervention is beta blockers. Okay, so again, obviously, not for a patient whose blood pressure is crashing and we're actually resuscitating with blood products, but for those more stable bleeds, we'll start them on beta blockers. Beta blockers are given to also reduce portal hypertension by decreasing heart rate and cardiac output and causing splanchnic vasoconstriction. So by lowering the pressure in the portal vein, beta blockers help prevent that formation of new varices and reduce the risk of existing varices from rupturing and bleeding. The prophylactic use of beta blockers has been shown to significantly improve clinical outcomes, reducing both the incidence of variceal bleeding and the overall mortality in patients with cirrhosis. Okay, and the last aspect of caring for esophageal varices patients are all the procedural interventions, namely endoscopic variceal ligation, transjugular intrahepatic portosystemic shunts, or the TIPS procedure, and my favorite, balloon tamponade. So let's talk through each one. Endoscopic banding or variceal ligation is where they go in with a camera, like endoscopically, to find the varices, and then they place little baby bands around them, almost like strangulating them so they can't rupture and bleed. This is done in the endo lab or even at the bedside if the patient's too unstable to travel to endo. It's actually pretty cool what GI providers can do, like what they're capable of through an endoscope. Next is the TIPS procedure. Again, TIPS is transjugular intrahepatic portosystemic shunt. I just say TIPS, it's so much easier. This is basically like a detour around the congested cirrhotic liver. Think like a detour whenever traffic's really congested. So a channel is created within the liver. Again, this is all done through like interventional radiology. A channel is created within the liver to connect the portal vein, which carries blood from the gastrointestinal organs to the liver, to one of the hepatic veins, which carries blood from the liver to the heart. So not every patient is a candidate for this procedure, this bypass procedure, but it can drastically improve symptoms for those patients that are candidates. And finally, and my favorite, balloon tamponade. So you might have heard this called a Blakemore tube or a Minnesota tube. They're a little bit different, but I won't get into the specifics of each tube, but the summary is these are tubes that can apply internal pressure onto the bleeding varices. Like you can't hold pressure on the esophagus from the outside like you can for other bleeding vessels. So the Blakemore tube or the Minnesota tube, they're kind of like a mix of like an NG tube with a Foley catheter with one of those like long balloon, animal balloons. So if you mix all three together, you get a Blakemore tube. So if it's decided we're going to place a Blakemore, the first thing to do is check all the balloons by inflating them underwater and looking for bubbles to ensure that there's no leaks in the tubing itself. Then the provider places the tube kind of in a similar fashion to how you would place an NG tube or an OG tube on an intubated patient. So you advance the Blakemore tube down into the stomach, and once you're confident you're in the stomach, then you blow up the stomach balloon, take an x-ray, make sure you're actually in the stomach, and you pull back the inflated balloon until it's like at the neck of the esophageal sphincter. So that's balloon number one. Then the second balloon, that's the long balloon animal one. So that's the long balloon inside the esophagus. That's inflated, and that's what places internal pressure inside the esophagus to tamponade off the bleeding vessels. Then you have to secure the thing so it doesn't move around, because moving around could be very problematic. So back in the day, like when I started out as a nurse, we would secure Blakemore tubes to football helmets. But now we skip the football helmet and attach the end of the Blakemore to a roll of like bandage dressing tied to a liter of fluids, draped over an IV pole to provide some traction to hold the tube in the correct location. So once you have the right amount of traction, then you can attach it securely to the ET tube securing device. That was a lot. This is very hard to visualize from the audio format of a podcast. So if you check out the show notes, I provided a link from first10em.com because they have, to me, the best thorough breakdown of how to perform the procedure, how all the tubes and ports and balloons work. So check that out if you want to kind of conceptualize what I was just describing. Quick funny story about Blakemore tubes. So recently I was walking through the ER after dropping off a patient that I had brought up from rapid response. When I heard through the curtain of a patient's room, our intensivist call out, "Is that Sarah out there?" And I called back, "Yeah, it's me. Hi, at your side." He said, "What's the chances you have a screwdriver in your fanny pack?" I chuckled and said, 100%, 100% chance I have a screwdriver. You want a Phillips head or a flathead? He started laughing and said, "How did I know you would have a screwdriver on you?" So as I entered the room, I was taking my multi-tool off my fanny pack, and I saw an intubated patient wearing a football helmet with a Blakemore tube in place. The patient had the Blakemore placed at another facility, and I guess they still used football helmets to secure their Blakemores, and the cage of the helmet was blocked by the ET tube, and they couldn't get it off the patient without disassembling the helmet cage itself with the screwdriver. Fortunately, my multi-tool screwdriver was up for the job, and they were able to get it off pretty easily while I beamed with pride in the corner as my fanny pack once again had exactly what the patient needed. Anyways, I'm getting off track. The summary is balloon tamponade is a good temporary option for bleeding control until another intervention like a TIPS procedure or endoscopic ligation can be achieved. Okay, let's summarize. So liver failure can lead to a bleeding esophagus through the development of esophageal varices caused by portal hypertension resulting from cirrhosis. Oof. These fragile varices are prone to rupture, leading to severe bleeding, and managing this condition involves a combination of careful blood transfusions, ensuring calcium levels are maintained, and using pharmacological interventions like octreotide, antibiotics, and beta blockers to reduce that portal pressure and prevent complications. And then procedural interventions like endoscopic variceal ligation or the TIPS procedure or balloon tamponade, these provide critical measures to control bleeding and improve patient outcomes. So as nurses, it's important to understand the why and the how behind all these interventions so that we can anticipate what's next and explain the plan of care to the patient, the family, and know what to look for and how to monitor these patients. Y'all, I could have gone on for hours and hours because there's so much to talk about with liver pathophysiology. But I look forward to the next 2 episodes. We'll be discussing some other aspects of liver failure. Next week is on hepatorenal syndrome. And the conclusion of this liver series is going to be on hepatic encephalopathy and managing patients experiencing alcohol withdrawal. So, till next time.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, Nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me, and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.